Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In episode 2 of this 3-episode series, we focus on a discussion of guideline-based treatment for NTM lung disease, led by Charles L. Daley, Professor of Medicine in the Division of Mycobacterial and Respiratory Infections at National Jewish Health in Denver, Colorado. He is joined for a case discussion by his colleagues, Shannon Kasperbauer, Associate Professor of Medicine in the Division of Mycobacterial and Respiratory Infections, also at National Jewish Health in Denver, Colorado, and Pamela J. McShane, Professor of Medicine at the University of Texas Health Science Center at Tyler. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear first from Dr. Daley on guideline-based treatment for NTM lung disease.
Now we're going to focus a little bit on guideline-based treatment. So the NTM guidelines will be really what I'm focusing on in terms of recommendations. As you know, they were revised and published in 2020 in both CID and the European Respiratory Journal. And then in 2022, you may or may not know that in Lancet Infectious Diseases, we published a consensus document on the other NTM, the ones that we could not address in the guidelines. So that's mainly there for your information. I'm going to focus on MAC. It turns out in the last couple of years, there have been 12 species of MAC. 12. But most of you don't know that because your lab doesn't tell you that. It tells you you have M. avium complex, maybe M. avium intracellulare, maybe avium, maybe intracellulare. But it probably doesn't tell you about these others. And that's because you don't see them very often. Maybe they're not very pathogenic. But would you treat someone the same if they grew para-intracellulare as opposed to intracellulare? This is an important question. I don't necessarily have the answer. And, taxonomy, nomenclature changes with time. So the species that you see here that are highlighted are now subspecies or about to become subspecies. But you still need to know if it's chimera. Even though chimera is now a subspecies of intracellulare, you need to know that as a clinician, as an epidemiologist, as a person in infection prevention. You need to know the species. So talk to your laboratory. Most of the time when we're thinking about treatment, though, we're not thinking about the species because we don't have that information. What we're thinking about is the patient, and we're trying to make that very difficult decision. Do you initiate treatment or do you go into watchful waiting? In the guideline, we said in patients who meet the diagnostic criteria, we suggest initiation of treatment rather than watchful waiting, but particularly in the setting of people who have a positive AFB smear, cavitary disease. But there are other risk factors that I think are helpful when you're sitting in clinic and you have a patient and you're trying to decide what to do. We know that male sex, older age, comorbidities, low BMI have been associated with progressive disease. The low BMI is usually less than 18.5. Laboratory factors associated with progression, increased CPR or CRP, increased SED rate, anemia, low albumin, and as I mentioned, radiographic factors, which I think are one of the things we really lean on when we're trying to decide. Because if we see fibrocavitary disease, I am not going to go into watchful waiting. I'm going to initiate treatment. And then the microbial factors, probably again, one of the most useful clinical things for you is the bacterial load. You can measure that by smear. You can measure that by the number of cultures, semi-quantitative culture data if you have it. And species is important, but I don't think we yet know how important. Whether you go into watchful waiting, whether you initiate antimicrobial therapy, 80% or so of these patients have bronchiectasis, so they should be on airway clearance. There are different ways to do this, and I think this is, again, it's good to engage your pulmonary colleagues to kind of help you get them onto a good airway clearance regimen. We try to get them to stop smoking. We all do that. Nutrition is very important. We do a nutritional assessment and try to address those needs. And of course, their weight management, meaning we're trying to get weight back on them. Exercise is good for all of us, but it's also a good way to do airway clearance. And GERD is very common in this population, so we look for it and we treat it when we find it. Let's get a patient perspective regarding airway clearance.
And though I was being treated by a local pulmonologist who kind of knew what the course was, he had other people who were much older than me. And in fact, he was very shocked that I didn't fit the profile of his profile anyway. I guess they decided that they had done sensitivity testing and they saw that I had a hope for those 3 antibiotics. When that didn't work, they switched the antibiotics, they retested me, and then I didn't have MAC, I had Mycobacterium. So they changed the protocol on me. And at that point, I was improving, but I never could get rid of it. My culture was always positive for the next 14 years on oral antibiotics. And I was on them constantly with a 3-month drug holiday yearly. And when it got worse, I was put on intravenous antibiotics, 2 rounds for 8 weeks each. And after that, I wound up getting my first negative culture in 14 years. Since then, I've been doing airway clearance religiously every day. I don't miss it. And I use 3 different means of airway clearance. I use nebulized saline, an aerobica, which is a PEP device that loosens mucus, and a bed, which loosens mucus too. And I really don't want to go on antibiotics again if I don't have to. And if I have to, I will. But it's been about 8 years that I have not been on antibiotics. And that's why I'm doing better. I feel like I have much more energy. I'm not coughing as much. And I'm happy with where I'm at right now.
So these are some data that actually show that something is beneficial when you start airway clearance in this patient population. This is a relatively small study. It was retrospective in patients who had NTM lung disease who, for various reasons, were not started on antimicrobial therapy initially. And it turns out about half of them had been started on chest physiotherapy or airway clearance. And when you look at one of the most important symptoms that a patient has is cough, look what happens over time in those who did start airway clearance versus those who did not. So cough decreased at 6, 9, 12, and 24 months in those who started airway clearance. And that's the figure at the bottom. You can see the cough is declining over that 24-month period. And that was highly statistically significant. And cough kind of bounced around in those who didn't start airway clearance, and there was no trend even in decreased cough. So you can actually improve the cough in the patient, probably their most common symptom, by doing airway clearance. Now, if we're going to start antimicrobial therapy, we're going to be guided by antimicrobial susceptibility testing. For MAC, we recommend testing amikacin and macrolides, and clarithromycin is the class drug. So the cut point for IV amikacin, the cut point for resistance is 64 or greater. It's a dilution higher for liposomal amikacin at 128 or greater, and the cut point is 32 or greater for clarithromycin. We also have recommendations both in the guidelines and the CLSI recommendations for kansasii. It's rifampin should be tested. For abscesses, macrolides and amikacin, just like with MAC. And for xenopi, we really don't know, and we couldn't make any recommendations in the guidelines for that. And there are other organisms for which we just don't know what the right cut points are. These are recommended to be tested because we do have clinical correlation with those specific resistance cut points. And we do not have that with the other drugs, hence they're not recommended to be tested. So if you have someone with macrolide susceptible treatment, this is our first line, it's pretty straightforward. The most important thing for you as a clinician is to know is it macrolide susceptible or not, and we're going to say it is. And in this setting, you have to decide how to give the regimen based on the phenotype. So for nodular bronchiectatic disease, we can give this 3 times a week. We give a 3-drug regimen, macrolide-based, azithromycin preferred, and you can give it for 3 times a week. If you don't want to use 3 times a week dosing, that's your choice. You can give it daily. But in the setting of cavitary or otherwise severe disease, we do recommend that that be given daily and that be combined with a parenteral aminoglycoside like amikacin for the first 2 to 3 months, and that you can give 3 times a week. We'll talk about macrolide resistance in just a few minutes, but basically we start parenteral amikacin in these patients, and we have to build a regimen of other drugs, and this is when we're considering surgery, or just one of the times that we would be considering surgery. If you take this approach, these are the expectations based on what's been published. In macrolide susceptible non-cavitary disease, culture conversion occurs in 76 to 88%. It drops in cavitary disease, and the range that's been published is 50 to 80%. But microbiologic recurrence is very common. 25 to 48% of patients who you think are cured, they will come back with microbiologic failure. And 46 to 75% of those individuals, it looks like they have a different strain or species, so they are reinfected. In the setting of macrolide resistance, it's quite different. David Griffith published when he was at Tyler many years ago, really a seminal paper on macrolide-resistant disease. And in patients who had no surgical resection and received no prolonged aminoglycoside, culture conversion was only 5%. In a study we did in Korea, in selected patients, we did do surgery and we did provide aminoglycosides, and we got the culture conversion up to 15%, but still quite suboptimal. And in that original paper by Dr. Griffith, in those patients who did have surgical resection and got prolonged parenteral aminoglycoside, and by the definition of that was over six or more months, he was able to get culture conversion almost back to 80%, but at great cost to the patient because the patient had surgery and ototoxicity, of course, with such prolonged therapy. So we do not want to treat macrolide-resistant disease. We want to prevent it from ever occurring by doing a good job at the beginning in terms of selecting a 3-drug regimen. But it's very clear from those data that there are some people who do not culture convert. They do not respond to that initial therapy. In the 2020 guidelines, we define this as treatment refractory disease, and that's any patient who is still culture positive after at least 6 months of therapy with guideline-based therapy. And one of the only novel recommendations in the 2020 guidelines was related to what you do with these patients. And that was, we recommended adding ALIS to standard oral regimen. And the reason we recommended that is we have very good evidence to support that. I think you've all seen it by now, but this was the CONVERT study. It was the phase 3 trial. This was a randomized trial. Patients with refractory disease, as I described before, were randomized to get ALIS plus guideline-based therapy or guideline-based therapy alone. And on the y-axis, you see the percent who were culture converting. By month 1, we were already seeing separation in the culture conversion rates. And by month 4, it was 29% culture conversion in those who received ALIS and about 9% in those who didn't. We learned a very important lesson here, something we had been doing for many years. When they were still positive at 6 months, we just kept the same drugs going. And no surprise, it doesn't seem to work. One of the things we didn't know when we wrote the guidelines was, did it last? How long did the culture conversion last? So Dave Griffith published this in 2021. He looked at those people from CONVERT that did culture convert and then wanted to see, was it a durable and was it sustainable culture conversion? He defined sustainable as they stayed culture negative throughout their 12 months of treatment. He defined durable as they were still culture negative after 3 and 12 months off of treatment. So you'll see here those percent who culture converted, very clinically significant difference, borderline statistical significance. So 63% of those who received ALIS and guideline-based therapy remained culture converted, but that dropped to only 30% in those who did not receive ALIS. And somewhat remarkable, by 3 months and 12 months off of therapy, none of those who did not receive ALIS stayed culture converted, and about half of those who had converted remained culture converted. So it was both sustained and durable. Now, I mentioned macrolide resistance. You will sometimes see a patient who has this. Usually they have been treated before, almost always. And there are certain factors that have been associated with treatment outcomes, which helps me think about how to treat them. So we know improved outcomes. I've already mentioned those who had surgery or parenteral aminoglycosides. Another study showed a low CRP was associated with improved outcomes. And this is very important. No difference in outcomes has been associated with continuation of the macrolide or addition of a fluoroquinolone. They don't seem to make a difference. And we actually have worsened outcomes when you stop ethambutol. So that's something we don't want to do. And probably not surprisingly, those with cavitary disease do not do as well. So this is how I think about it when I'm treating someone with macrolide resistance. I stop the macrolide. Data shows it doesn't improve outcomes. I continue the ethambutol because data shows it does improve outcomes. I consider switching from rifampin to rifabutin because rifabutin has a bit more in vitro activity. As I've mentioned, I start a parenteral amikacin, and I usually transition to ALIS after the first couple of months of the IV. Then you have to build that regimen, so you'll need some in vitro guidance to try and find drugs that might have activity. You're still trying to build, to 3 to 4, usually 4 drugs. I don't add isoniazid. This is recommended in the British thoracic guidelines, but it really has no activity against MAC. I think it's all risk and no benefit. I don't add a fluoroquinolone, not associated with any improvement. Definitely consider surgical resection. And here's where I say, consult an expert. I think it's a good idea. These are complex patients, and this is often your only chance. This is right now to cure them. So I want to end with a couple of other slow growers that we addressed in the guideline. Well, the first is M. kansasii. This is my favorite NTM. When I see one coming to clinic, I'm like, this is going to be a good clinic. The most important thing is not the macrolide for you, but rifampin susceptibility has traditionally been the drug in which if we have resistance, the outcomes are worse. So let's say we have susceptible disease. We think of just like MAC. If they have nodular bronchiectatic disease, you can give the same regimen 3 times a week. Sometimes we have patients who have MAC and kansasii, so that's an easy fix. We just treat them with the same regimen. If they have more extensive disease, cavitary disease, we're going to go to daily therapy, just like we did with MAC. Here, though, you have an alternative. You could, instead of using a macrolide, use isoniazid. But in this setting, it should be daily therapy because there are no data that have looked at 3 times a week like we have with the nodular bronchiectatic macrolide regimen. And also one thing that's different than the other NTM is the treatment duration is at least 12 months of therapy, not 12 months beyond culture, but just 12 months of therapy. We could find no evidence that treating longer had any benefit, so that's why we said 12 months. Now, if they're rifampin resistant, it gets harder, but not like macrolide resistance. Usually it's a macrolide, a ethambutol, and we'll usually substitute moxi or another fluoroquinolone. The bottom line is these patients do really well. Unlike these patients. Mycobacterium xenopi or xenopi, here we look, is it macrolide susceptible? If it is, a nodular bronchiectatic disease, it's a MAC regimen. But here we would consider, in addition to the macrolide, actually adding moxifloxacin. There's some in vitro data showing that is actually quite active. If they have more extensive disease, it's the same regimen, but we would add IV amikacin. I didn't mention IV amikacin with kansasii because we don't need it. I mean, we cure them without it. Treatment duration, same as MAC, and like macrolide resistant MAC, this is a very difficult organism to treat. We consider surgical resection. These are the outcomes, and this is why I'm saying that I like kansasii, but I don't like the xenopi. This was a systematic review that looked at the published data and the outcome. So with kansasii, most of the regimens that they reviewed included rifampicin and ethambutol, and the pooled relapse-free culture conversion was 80%. The pooled relapse-free culture conversion when using an ATS recommended regimen was 100%. You're going to cure these people. And this, as you can see in the forest plots, how that varied. Now look at xenopi. Here, many regimens were used. There was not one that really predominated. And look at the relapse rate or the conversion here, 32%. Look at the all-cause mortality, 38 to 69%, because these patients almost always have underlying lung disease like emphysema. And they are very difficult to treat and they die. And here we have a lot more spread in the studies looking at the conversion rates. So love kansasii, don't like xenopi. That's when we have to think about surgery. So we recommended that you consider surgical resection and following an expert consultation. We said this because we did our own systematic review. We found 15 observational studies, about 700 patients, and in 300 of those patients, the studies compared those who had antimicrobial therapy plus surgery versus antimicrobial therapy alone. The bottom line is culture conversion was more common in those who underwent surgery. Complications were 7 to 35%. The 7 was at the University of Colorado, and those patients all underwent VAT surgery. There was no operative mortality across the 15 studies, 0 to 9% post-operative. Again, 0 was at University of Colorado. But we say beware of selection bias. We all know these are highly selected patients. Not everyone can go to surgery, and hence that's why we recommend following expert consultation to help you figure out, is this the best pathway for the patient? If you start therapy, we're charged with monitoring. And so we're monitoring for 2 reasons: treatment response and adverse drug reactions. To identify refractory disease, we need cultures. So that's how we tell that they're still culture positive at 6 months. And importantly to the patient, they know this rule. They want to get off treatment. They want to know when that culture conversion occurs because they're going to get treated for 12 more months for all of the NTM except for kansasii. We're also looking for adverse reactions. We said this should be individualized because during the development of the guideline, we found literally nothing that told us the best way to monitor patients. But things that we thought you should look at were blood counts, CMP, visual acuity monitoring, and when they're on the IV therapy, you should be doing audiograms. All right, now we're going to hear a little bit about what this patient thinks about treatment duration.
It takes a year from the time I go to the doctor till they do all kinds of tests and they think about various routines before I'm finally on treatment again. So I end up with 2 years on drugs, 2 years off of drugs. What helps me now is realizing that is the process. I'm going to be 2 years on, 2 years off. I shouldn't be surprised when I finish this cycle that it's going to come back with something else. I've told people I don't fear the disease anymore. In the beginning, I was afraid of it because I didn't know what it would do. Now it's just something that has to be managed. And I look at it, my choices are up front. I can do this treatment or I can slowly lose the ability to breathe. And that's not comforting. So, I feel I have to do it.
MAC disease should be treated with 3-drug, macrolide-based, azithromycin preferred, 3 times a week if you would like for those who have nodular bronchiectatic disease, daily for those who have cavitary disease, and you should consider 2 to 3 months of IV. That you can give 3 times a week. Treatment refractory, ALIS should be added. M. kansasii, 3-drug regimen. It's a MAC regimen, very straightforward. I would prefer that over the isoniazid regimen. Xenopi, 3 or more drugs, probably 4 for most patients, and consider surgical resection when possible. And the treatment, as I said, is 12 months beyond culture conversion for all except kansasii. So let's take a case. So this is a patient. This is a 53-year-old white woman from Florida with a history of bronchiectasis, recurrent respiratory infections. And she'd been previously treated for Mycobacterium avium about 2 years ago. And look at the regimen, clarithromycin and moxifloxacin. So that's not what we recommend, but that is the regimen. And the reason for that is because they looked at their drug susceptibility list. It had all these drugs that don't have cut points for resistance, and these are 2 that had an S by it. And the others, rifampin did not, ethambutol did not, but we don't care because those we're going to use regardless of the MIC. So that was a mistake. But now she's got a chronic cough, mostly dry, fatigue for several months. Underlying comorbidity is Sjogren, for which she's on hydroxychloroquine. On exam, she's thin. Her BMI is below that 18.5 that I mentioned is associated with progression. Some inspiratory squeaks on exam. She's got a mildly elevated CRP. She's got a hematocrit a little bit low, hemoglobin a little bit low. She had 3 induced sputums because her cough was mostly dry. All were AFP smear negative. And where she grew avium before, she's now growing chimera, which remember is a subspecies of intracellular. So I'm going to take just a second. I'm going to query my friends up here. So with this information, would you treat or watchful wait?
I would treat.
You would treat?
Yeah.
Okay. All right. So let's think about that, because what are her risk factors for progression? She has a low body mass index. She has comorbidities, in this case, Sjogren's and bronchiectasis. Because you see in the CT scan, she's kind of got the right middle lobe, lingular bronchiectasis, but she actually, other slices, she has some other tree and bud nodularities. She's got an elevated CRP, borderline anemia. And the other thing, she's got 3 out of 3 sputum that are positive, so fairly high-grade sputum. And these weren't done in the same day or in 3 days. They were spread out. Now we have a line probe assay. You've got this back. There were no RRL or RRS mutations, so the isolate's considered macrolide and amikacin susceptible. Phenotypic results eventually confirm susceptible. So she started on a 3-drug macrolide-based regimen, 3 days a week. Would you give 3 days a week, or PJ?
So I think for now we can stay on 3 days a week. We don't have a cavity. Was she losing weight?
Yeah.
Oh, okay. Then I might do daily for now.
Daily. Yeah. 3 times a week. See, this is your decision. It's what you're comfortable with, but either is appropriate. So she was, we did the baseline assessments before starting therapy and monitoring therapy, as I said, monthly sputum cultures, and then looked for any adverse events. She's one of these that was treatment refractory. She did not convert. I was kind of surprised she did not convert, but she did not convert. So she was started on ALIS per guideline recommendations. And as happens in 50% of people who get ALIS, she had dysphonia. She was hoarse and actually to the point of almost losing her voice. So we decided to hold the Alice. Voice got better, and then we started things slowly. And we've been doing this now for years, I think all of us, where we slowly start maybe Monday, Wednesday, Friday, until we get them back to daily if we can. Sometimes we end up at 5 days a week. But we're aiming to get to 7, which is where the evidence comes from. But I'm just curious, any other tricks? So Shannon, besides this hold, any other things you do when people get worse?
Yeah, nighttime administration can help often.
Nighttime? Okay.
To rest their voice throughout the night when they're sleeping, so they're not doing it at the beginning of the day. A lot of patients have really liked using certain lozenges or gargling after they use it, so those factors will help.
Drinking a beverage during, whether that's hot or cold, specifically to it can be specific to the person. But I do think that interrupting of the treatment, whether that's starting at once a week, then going to twice a week, then 3 times a week, I think it empowers the patient to help them feel like they're in control of it, and they feel a little bit more confident about moving forward with it.
Okay, thank you. She stayed positive, so she actually ended up going for VATS. She had a right middle lobe and lingular resection. They were separated by about 8 weeks. She culture converted at that time, which about 80% of people who go to surgery do. So she got 12 months beyond surgery. And she did well and she was cured. And so far, no reinfection.
I'd like to thank Dr. Daley, Dr. Kasperbauer, and Dr. McShane for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on clinical case studies in nontuberculous mycobacterial lung disease, expert insights on best practices on the Clinical Care Options website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.